So we're going to continue with the investigations that you should do uh, when you have a patient with atrial fibrillation. And of course, the BNP, which is the brain natriuretic peptide, uh, because a lot of these patients are in heart failure. The atrial fibrillation can push them in heart failure, and so you do a BNP. But even if they're not in heart failure, an elevated BNP portends a poor prognosis. So just getting a BNP, can give you an indication how well the patient is going to do. Sleep study. We know that obstructive sleep apnea is associated with atrial fibrillation. A lot of these patients do have atrial fibrillation. So if you can establish a diagnosis of obstructive sleep apnea and you treat the sleep apnea, you may reduce the frequency or you may even eliminate the atrial fibrillation. And rhythm monitoring. It's sometimes good to put an Holter monitor on or event recorder. Holter monitor to help to establish the diagnosis if you suspect it. Sometimes we even put a loop recorder in, implanted loop recorder to make the diagnosis because sometimes it's so infrequent. Or we do a stress test. But one of the reasons for the stress test is if you have a patient with atrial fibrillation and they continue to tell you that they are very short of breath when they do any activity, you may want to do a stress test to sort of mimic activity and see how well their heart rate is controlled. Because in order to properly treat atrial fibrillation, we not only want to reduce the resting heart rate, but we want to reduce the exercise heart rate. Yeah, you want to get the heart rate increase with activity, but some of these atrial fibrillation patients, as soon as they do any activity, the heart rate skyrocket, and that's going to make them short of breath and not feeling well. So you want to control not only resting, but also exercise heart rate. As we had mentioned before, you can do prolonged or frequent monitoring. The loop recorder, sometimes it's implanted, especially if you have a patient who presents with, say, syncope, uh, and you just don't know why the patient is passing out. You put a loop recorder, they may have bouts of atrial fibrillation and then a pause. Because a lot of time when atrial fibrillation breaks, it breaks with a significant pause. So they have atrial fibrillation break with a 6 or 7 second pause. That may explain the syncopal episodes. Of course, if they're in the hospital, then telemetry monitoring, we mentioned Holter monitor, mentioned event recorder. And it can be patient activated or non-patient activated. So if you have not established the diagnosis of atrial fibrillation, you suspect it, then you have to send these patients home with some type of monitoring device. Even if you control or you convert the patient to sinus rhythm and they're still having symptoms, you may still have to send the patient home with some type of monitoring to see if they're getting breakthrough, to see if the atrial fibrillation is still occurring. And we mentioned the stress testing to make sure that the exercise rate is not excessive. As we had mentioned before, one of the problems with atrial fibrillation is strokes. You get a significant increase in the risk of thromboembolic phenomenon, and stroke is one of the most devastating thromboembolic phenomenon one can get. And you can get this with any type of the atrial fibrillation, the paroxysmal, the persistent, or the permanent, or even the silent or asymptomatic um, atrial fibrillation. We had made a distinction between valvular and non-valvular atrial fibrillation, and that distinction is very important because when we talk about atrial fibrillation, what we're usually talking about is non-valvular atrial fibrillation. And again, the definition of valvular atrial fibrillation is atrial fibrillation as a result of mitral stenosis, mitral valve replacement, and mitral valve repair. So those are your valvular AF. And the risk of strokes with your non-valvular atrial fibrillation is about 5 times that of the general population. The risk of stroke with your with your valvular AF is much greater than that. Okay, so with your valvular AF, the risk of stroke is tremendous. So atrial fibrillation in a patient with mitral stenosis increases the risk of stroke 20 times that of patients with sinus rhythm. So patients with valvular atrial fibrillation have to be treated with warfarin. That is the gold standard. You cannot use the NOACs. You cannot use the newer oral anticoagulants to treat your valvular atrial fibrillation patients. So how do we prevent thromboembolism? Because this is one of the vexing problem associated with atrial fibrillation. It's one of the most devastating things associated with atrial fibrillation. So how do we prevent it? Well, we know that if you have had a stroke, a prior stroke, you're at a much higher risk of developing another stroke. So, and once you have had a stroke, you have demonstrated that you can and will have more strokes. And if you have had a stroke, then or any type of traumatic problem, it increases your mortality and morbidity. So also, silent atrial fibrillation is associated. You might say, well, I have atrial fibrillation, but I don't have any symptoms. Yes, you're still at increased risk for thromboembolism and stroke. Okay. So some of the risk factors for atrial fibrillation, we discussed them before. So you need to treat the patient hypertension, the cholesterol, and by doing that, you're not only going to reduce the stroke risk or the risk for atrial fibrillation, but also the atherosclerotic risk. Now, unfortunately, these are things that you have to know, but we're going to sort of break them down a little bit. So these are class 1 indications for therapy in patients with atrial fibrillation. So in patients with atrial fibrillation, antithrombotic therapy should be individualized on a shared decision making after discussion of the absolute risk. So what we're saying is that you have to talk to the patient, and you have to explain to the patient that they're at an increased risk, and you give them the information in terms of therapy, and then they can say, well, I don't want X, Y, and Z, give me whatever therapy. So it should be an informed decision. Okay. Now, your selection of the antithrombotic therapy should be based on the risk of thromboembolism, irrespective of whether the AF is paroxysmal, persistent, or permanent. And we're going to go over that. We have a, a method of assessing the risk of individual patients. So you need to apply that and determine that patient's risk of developing a thromboembolism or a stroke. Okay, so these are things that you have to do. You have to talk to the patient, and then we have a scoring system we call the CHADVAS scoring system. And we're going to go over this, but this is a scoring system that gives you the stroke risk. Okay, it gives you the risk of you developing a stroke. And if you're high risk, then you should be treated. Okay, so you have on each patient you have to apply the risk score. So as we have mentioned before, for patients with atrial fibrillation who have a mechanical heart valve, and so we're talking about, this is not a valvular AF now. So atrial fibrillation for a patient with a mechanical heart valve, warfarin is recommended, and it depends on the location of the prosthesis. But as we have discussed before, valvular atrial fibrillation is atrial fibrillation in the setting of mitral stenosis, mitral valve replacement, or mitral valve repair. But if the patient have a mechanical valve in any other location, then you have to give them warfarin. Remember, mechanical valve needs warfarin. The NOACs do not treat, do not prevent clots when you have a mechanical valve. So for non-valvular AF patient with a prior stroke, they're at a very, very high risk because they have demonstrated to you before that they can form clots and they can have a stroke. So you're still gonna use your CHADVAS score, and you not more likely, those patients are gonna need to be anticoagulated. Okay? All right. So if the patient is unable to take if the patient is unable to take warfarin, or you cannot control, well, they're up. I'm not going to even mention this because the guidelines have been up. Remember, this is the 2014 guidelines, and I am using it because it goes through everything. When we come to the 2019 update, then we're just gonna update those information that need to be updated. So I'm not going to mention the last, but the class 1 indication, you have to talk to your patients. Okay, you have to use your CHADVAS score to individualize which patient needs to be anticoagulated. And then there's a thing we call bridging now. Uh, when we say bridging, what we mean is, say for instance, the patient have, say, a mechanical heart valve. You know, those patients have to be anticoagulated. And say you need to do a procedure. Say you're going to do a minor surgical procedure. You don't want to stop the warfarin for too long. And you may have to put that patient in the hospital and give them unfractionated heparin or low molecular weight heparin for a period of time. So you're going to stop the warfarin because you don't want to do a surgical procedure and the patient is on warfarin because they can bleed profusely. So you stop your warfarin, you put the patient in the hospital, you stop the warfarin, and you give them unfractionated heparin or low molecular weight heparin. You can stop your heparin and the effect is gone in a couple of hours. So you can do your procedure and then restart the unfractionated heparin and then transition them back to the warfarin. So, that's what we call bridging. And when you're going to bridge someone, you still look at the risk of developing thromboembolism because, you don't want to stop the warfarin for say too long. Or if say for instance the patient just have atrial fibrillation, even with regular atrial fibrillation, you don't want to stop the blood thinners for too long because if the patient have a very high chance of developing clots, then stopping it for 4 or 5 days, the patient may develop a clot and get a stroke. Okay, and it's real. I've had patients who have had that. The surgeon think that 4 or 5 days is not long, and the patient had a stroke. So you have to look at the individual patient. If the patient have a high risk of developing a stroke, you better bridge them. Okay. All right, let's move on. So those are your sort of class 1 indication, and a lot of that information is updated. So we'll go over the updates. So again, for patients with non-valvular atrial fibrillation, um, the CHA2DS2-VASc score of 0 is you want to call it a real 0. Before the CHA2DS2-VASc score, we usually use something called the CHAD score. And the problem with the CHAD score is that the 0 was not a real 0. When someone has a CHAD score of 0, they're still at an increased risk of strokes. So we weren't sure, which of those 0 patients we should give blood thinners. Whereas when we use the CHA2DS2-VASc score, which is a more scoring system, 0 is a real 0. Your chance of getting a clot or thromboembolism is extremely low. So CHA2DS2-VASc score of 0, you probably shouldn't give them any blood thinners. Okay. But for a CHA2DS2-VASc score of 2 or greater, then you should give them blood thinners. You can use your NOACs or your warfarin. If the patient have chronic kidney disease, which is a lot of our agents, it prevents the elimination of the agents, and you have to adjust the medication, and we're going to go over that, so I don't want to confuse you. We're not going. So the important thing here is patients with a CHA2DS2-VASc score of 0 or 1. You may not have to give these patients blood thinners. Again, if the patients have kidney disease, you have to adjust the medications. And we're going to look at the different medications and which of the medications need to be adjusted. Now, you have to know class 3 indication. For anything, you have to remember class 1, you definitely have to do. Class 2 is a little iffy. Class 3, there's no benefit or there may be harm associated with class 3 indications. So class 3, the NOACs when you're looking at the NOACs, and those are the newer oral anticoagulants, and we talk about dabigatran, which is um, your Pradaxa. We talk about your factor 10A inhibitor, which is your rivaroxaban or Xarelto, or your apixaban or Eliquis. So if the patient have renal disease, then these agents, you don't want to give these agents. You don't want to give your dabigatran, which is your Pradaxa. You know, you can adjust the dose for renal compromise, and we're going to go over how much adjustment you're going to do. And then for your Xarelto, you should adjust. For apixaban Eliquis, there's not much adjustments needed. Also, very important, you don't want to give any of your NOACs to a patient who have mechanical heart valve. As a matter of fact, the patient, there was a study that they used Pradaxa, which is dabigatran, in patients with mechanical heart valve. And those patients get heart attack, they get all sort of stuff. The study had to be stopped. So you do not want to give patients with mechanical heart valve any of the NOACs. That's the newer oral anticoagulants. So the agents that we can use to prevent thromboembolism in patients with non-valvular atrial fibrillation is your unfractionated heparin, your low molecular weight heparin, the warfarins, the direct thrombin inhibitors, and we have only one direct thrombin inhibitor, which is Pradaxa or dabigatran, and the factor 10A inhibitors. I think we have a total of 3, which is your apixaban or Eliquis, your rivaroxaban or Xarelto, and then your edoxaban or Cerveza. We also have antiplatelet drugs, aspirin and clopidogrel, and there were studies that look at these antiplatelet drugs, and we'll just mention them. So again, we're talking about non-valvular atrial fibrillation. You have to look at the risk of a stroke versus the risk of bleeding. And the bleeding can range from just a minor bleeding to fatal intracranial or extracranial hemorrhage. So you have to not look at the stroke prevention only, but the risk of bleeding. There were numerous studies that showed that platelet inhibitors, that is your aspirin and clopidogrel, are less effective than your warfarin. And the bleeding risk associated with the platelets is probably about the same. So when a patient comes to you with atrial fibrillation, you have to determine the risk of thromboembolism. And when we say thromboembolism, we're really talking about strokes. What is the risk of that patient developing a stroke? So we started off with the CHADS 2 score, okay? And the acronym is congestive heart failure, hypertension, age, diabetes, and stroke. And the reason why we have a 2 year is because it's a point system. Each of these conditions, 1 point, but if you have a stroke, then you get 2 points. And then the CHADS 2 score was not adequate because what we said, when you get a 0, it's not a real 0. Okay, a lot of those patients who have a 0 score in the CHADS, they get strokes. So they developed the CHADVAS score, which is a much more complete scoring system. And the acronym basically, you have your congestive heart failure, your hypertension, age, and so in the CHADS 2 score, age was age greater than or equal to 75. So when we come to the CHADVAS score, we have two age separations. So if you're 75 and greater, you get a score of 2. If you're 64 to 74, then you get a score of 1. And of course, D is still your diabetes. Your S is a stroke or TIA. TIA is counted as a stroke, and you get 2 points for that. And then vascular, if you have had any vascular problem, myocardial infarction, peripheral artery disease, and then this is your sex classification. What we have found is that females are much more prone to thromboembolism than males. So being a female, you get 1 point. This is a bleeding. This is the bleeding score. It's called the Hasbled score. We don't use it too much, but it can help you somewhat. So this is your CHADVAS score, which is the current scoring system that we're using. Again, C is for congestive heart failure, and it doesn't, if the patient comes in with decompensated heart failure and they're having a diastolic heart failure, it's still classified as heart failure. So, if they have an ejection fraction of 40%, and they're not in heart failure, then you still class them as give them a 1 point. But if they come in and they're in heart failure and it's a diastolic heart failure, they still get 1 point. Hypertension, 1 point. Age greater than 75, you get 2 points for that. Diabetes, 1 point. Prior stroke or TIA, they get 2 points. Vascular disease, as we outlined before, get 1 point. And then the sex category, females, because they're at increased risk. So this is your CHAD score. This is a whole scoring system. So you can see when you have a CHAD score of 0, your risk of stroke is not 0. Okay, the adjusted stroke risk is 1.9. Okay, so and so this is the CHAD's 2 score, and the maximum was 6 points. But this 0 was not a real 0. So we moved to the CHADVAS score, okay, where the CHADVAS score, the 0 is a real 0, okay? So this 0 is a real 0 because the age adjusted stroke is 0. And these are the different categories as mentioned before: congestive heart failure, hypertension, age greater than or equal to 75, that's 2 points. Diabetes, 1 point. Stroke, TIA, or any thromboembolic phenomenon, 2 points. Vascular disease, again, prior myocardial infarction, peripheral artery disease, or aortic plaque. So aortic plaque, they get 1 score. And then age 65 to 74, they get 1 point. And then females, because they're at a somewhat higher risk, they get 1 point. And then the maximum scored for the CHAD is 9. Okay, so it's a much more complete scoring system. So this is what we're using now. Okay, we don't use the CHAD score, and these are the bleeding risk scores. The one that we use somewhat is the Hasbled score, and and again, it's an acronym. The acronym stands for hypertension, that's systolic blood pressure greater than 160, abnormal liver or renal function, stroke, bleeding history or a predisposition, labile INR, elderly greater than 65, drugs or alcohol. So if you have these conditions, it increases your bleeding risk. Okay, so you have to look at these things, and some of these things are sort of common sense approach. If your liver is shot and your kidney is shot, and you had bleeding before, your INR is all over the place, then you're gonna bleed. So a score of greater than 3 is potentially high risk for bleeding. So you wanna really make sure that the patient is gonna benefit from the anticoagulant. So your antithrombotic option. So remember, what you're trying to do is to prevent stroke or systemic emboli by reducing the formation of platelet-rich or thrombotic clots in the left atrium or left atrial appendage. So remember that in atrial fibrillation, the clots live in the left atrial appendage. So your regular transthoracic echo is not going to help you to rule out clots because the regular transthoracic echo cannot see in the left atrial appendage. So there were a number of studies that were done to see, can we prevent strokes in patients with atrial fibrillation? And some of the earliest studies looked at warfarin or aspirin compared with, nothing, just regular treatment. Then, we went on to compare aspirin with warfarin. Okay. Again, remember, aspirin is an antiplatelet, and then because of the issues related to warfarin, we wondered if we combine clopidogrel with aspirin and compare it to warfarin, what sort of benefit is it equivalent? And we have the newer the NOACs, the new oral anticoagulants, the direct thrombin inhibitor, which is your Paxa, and then the factor 10A inhibitors. Then we compare those with warfarin, because warfarin is the standard therapy up until recent. And these are some of the studies, okay? So the study comparing warfarin with placebo. Okay, so this is one of the early studies, and these are the studies. This is what we call meta-analysis, when we combine a bunch of studies to see if they're effective. And the ASAC, the SPAF, the BATAF, the CAF, the SPINAF, these are all, it's 1989, 1990, 1991. So these are some early studies comparing warfarin to placebo. And so anything to the left of the zero line show that there's benefit. So all the studies show benefit for warfarin. And then we went over to look at anti-platelet therapy compared to placebo. And so these are some of the studies that some early studies as well. And majority of the studies were to the left of the zero line, but there are a couple that were to the right. Okay, so anti-platelet therapy, aspirin. So they even use dipyridamole. Majority of the studies had aspirin in it. So it was better than, I would say, nothing. Okay. And then they look at warfarin compared to the antiplatelet therapy. Okay, and you can see that all these studies were, except just one, were to the left of the zero line, showing benefit of warfarin over your antiplatelet therapy. So and so these are some early studies, and these are the name of the trials. So the gold standard is warfarin. So again, the meta-analysis have summarized the effect of the antithrombotic therapy for stroke prevention, not valvular AF. When we look at all of them, only the SPA, stroke prevention atrial fibrillation, showed some benefit of aspirin alone. And that was not a well-done study. And I think that is not recommended at the present time. So aspirin alone for atrial fibrillation is not recommended. Um, when we look at warfarin or Coumadin, warfarin is a vitamin K antagonist. And we will show you the clotting cascade and show you where warfarin works or acts. And it's been around since the 1950s for stroke prevention, and it works in multiple sites. So this is the clotting cascade. You have an intrinsic pathway and an extrinsic pathway. Factor 12 activate factor 11, activated factor 11. So, when you have some sort of trauma and there's contact activation, then you're going to activate factor 12, factor 11. Factor 11 is going to activate factor 9. Then factor 9 is going to activate factor 8. And then your extrinsic pathway, which you tissue factor. The tissue factor is going to activate factors. So these are proteins in the blood. So tissue factor activate factor 7. Then factor 7 and 8 comes together and activate factor 10. So when we talk about factor 10A inhibitors, this is where these agents act. They prevent the activation, they inhibit factor 10. And the factor 10 inhibitors is your apixaban or Eliquis or rivaroxaban or Xarelto and edoxaban or Cerveza. So these are your factor 10A inhibitors. This is where they work. Okay? Where's your then your factor 10 activate factor 5, factor 5 activate factor 2. Factor 2 is thrombin. And as you know, when thrombin is activated, then it converts fibrinogen to fibrin clots to seal the wound or to prevent excessive bleeding. This is your clotting cascade. Your warfarin, which is a vitamin K antagonist, acts at factor 9, it acts at factor 7, it acts at factor 10, and factor 2. So these different factors, that's where your warfarin, okay? So factor 2 is thrombin. So your dabigatran or paradoxa inhibits factor 2, or it directly inhibits thrombin and prevents clot formation, fibrinogen going to fibrin clot. So this is just a simplistic diagram showing you where the different agents work. Okay, your warfarin, your factor 10 inhibitors, and your thrombin inhibitors. So these are the NOACs, or the new target specific anticoagulants. Again, we talk about dabigatran, which is paradoxa, rivaroxaban, which is Xarelto, apixaban, which is Eliquis, and edoxaban, which is Cerveza. All right, so let's quickly look at these. So the dabigatran was first approved in the US by the FDA. Again, as we showed you before, it acts on factor 2, so it's a direct thrombin inhibitor. And the study that was done was the RELY trial, which looked at dabigatran compared to warfarin. Because remember, warfarin is the standard. So you have to compare all the new therapy uh, warfarin. So the RELY is your randomized evaluation of long-term anticoagulation therapy. And there were two doses of your dabigatran. There's 110 milligram twice per day or 150 milligram twice per day, and it was a blinded fashion. And you use adjusted dose warfarin, okay? Because the warfarin, the INR should be between 2 and 3, so you have adjusted the dose warfarin accordingly. There were about 18,113 patients, and the median follow-up was about 2 years. And at that time, we didn't have the CHAD-VAS score, so it was the CHADS 2 score, and the average score, the mean score was 2.1. The primary outcome in the RELY was stroke of any type, systemic embolism, or any major hemorrhage. This is the time in therapeutic range. So, if you use warfarin, you know that not all the time your patient is going to be in therapeutic range. You know, you add them at a dose of 5 milligrams of warfarin. The INR was 2.7. Next month when you check it, it might be 1.9 or 1.8. So it's not all the time your patients who take warfarin is going to be in the therapeutic range. So this is the time in therapeutic range was 64%. Okay. So anyway, the primary outcome was assessed for non-inferiority followed by superiority. So you want to make sure that your new therapy is not inferior. If you can show superiority, then that's fine. What was found was that the 150 milligram twice per day was superior to the warfarin. The 110 milligram twice per day was non-inferior. Those of you who know what goes on in Europe know that the European dosing is 110 milligram twice per day, which is non-inferior. And the reason why they choose 110 milligram twice per day because they get less bleeding with that. Whereas in the United States, they use the 150 milligram twice per day, which was a superior dosing, a superior outcome to warfarin, but they at the expense of a little bit more bleeding. So the risk of hemorrhagic stroke was significantly lower. All your newer agents have lower bleeding, stroke, hemorrhagic stroke. So all the newer ones have. So right off the bat. So people who do an exam again. So all your NOACs have lower hemorrhagic strokes. Major bleeding was significantly decreased with the 110 dose, but not with the 150. So you're going to get a little bit more bleeding with the 150. It's a superior dosing schedule. Gastrointestinal bleeding was also higher in the 150 milligram twice per day. And these are the comparison. Dyspepsia. So, one of the problems faced with Pradaxa is dyspepsia. Patients complain of abdominal discomfort. And dabigatran is excreted by the kidneys. So you have to do dose adjustments. So if the creatinine clearance is less than 30 mLs, you want to So those patients were not studied in the RELY trial, but in practice, you're going to reduce if the creatinine clearance is between 50 and 30 mLs per minute, you're going to do half dose and 75 twice per day. Okay, so you're going to reduce the dose. Rivaroxaban, which is your Xarelto, again, that is your factor 10A inhibitor. Remember, it inhibits factor 10, 10A. So this is the second NOAC to be approved by the FDA, and it's a single dosing schedule, usually with an evening meal. It is also predominantly excreted by the kidneys. It is also excreted by the kidney. And the study that looked at this was the ROCKET AF trial, which is rivaroxaban versus warfarin non-valvular atrial fibrillation. They use Xarelto 20 milligrams and 15 milligrams. 15 milligrams is the creatinine clearance was between 30 and 40 mLs per minute. And they compared your rivaroxaban, that's Xarelto, with warfarin. They had 14,264 patients. And these patients had a little higher risk than the RELY trial. They had greater than 2 risk factors for stroke compared with the RELY trial. So the patients in the rivaroxaban group were somewhat older, and the mean CHADS-2 score. So again, we're still, it's an older study, so the CHADS-2 score was 3.47. The primary was stroke or systemic embolism, and it is a double-blinded trial. So again, warfarin, the time in therapeutic range was only 55%. So not all the time they were anticoagulated. And the study showed non-inferiority of rivaroxaban compared to warfarin. So it is not inferior. The major bleedings were similar. Again, less fatal and less intracranial hemorrhage were found. So again, all of your NOACs have less intracranial hemorrhage, which is a good thing. The other one is the apixaban or Eliquis. So it's another factor 10A inhibitor. The third NOAC to be approved by FDA. This one, though, is predominantly eliminated by the liver, not the kidney. So that is why the current recommendation is that if you have renal failure, this is the go-to drug. Okay? Renal failure, apixaban or Eliquis is the go-to drug. It is highly protein bound, and the study that looked at apixaban was the Aristotle trial, which is the apixaban versus warfarin in patients with atrial fibrillation. So again, warfarin is the standard of care. Warfarin is the standard of care. So you have to compare everything to warfarin. And they use apixaban 5 milligrams twice per day compared to warfarin. This is a double-blind, a randomized controlled trial, 18,201 patients. And again, these are old studies, so they use the CHADS-2 score. The score was 2.1. The interesting thing for apixaban is if you have older patients and age greater than 80, weight less than 60 kilograms, or creatinine greater than 1.5. If you have two of these three, you have to half the dose of your apixaban. So this is very important to remember. Older patients greater than 80, weight less than 60 kilograms, and creatinine greater than 1.5. Any two of these three, then you have to dose. Because remember, the regular dose is 5 milligrams twice per day. So the primary outcome was stroke or systemic embolism. And the mean the mean follow-up was 1.8 years. Mean age was 70. Again, in the warfarin treated group, the time in therapeutic range was 62%, and apixaban was significantly better than warfarin. Okay, and again, there are fewer overall strokes, both ischemic and hemorrhagic stroke, and also systemic emboli and major bleeding events, and fewer intracranial bleeds. So the NOACs have fewer intracranial bleeds. With apixaban, the GI bleeding complications were similar, however, and you have fewer deaths with apixaban than those in warfarin. So we're going to skip over this. This is comparing apixaban and aspirin. That's not a real study. They have to stop that. So essentially, those are the medications that we have to treat thromboembolism today, and they're very effective. You have to individualize your therapy, however. So you have to look at your patient as an individual. You have to apply the CHA2DS2-VASc score, and you have to use your HAS-BLED score as well to see if they're at an increased bleeding risk. And then you choose your agent. All right? So we're going to stop here. We went over, but we're going to stop here, and then we will continue on Thursday. So we'll continue on Thursday, okay? All right.